Good evening, everyone, and welcome to the Asian Geriatric Oncology Society webinar series on the theme Geriatric Oncology Unmet Needs. It gives me great pleasure to invite Dr. Prem Narasimhan, Geriatric Medicine Specialist from Mumbai, to give the welcome address. Over to you, sir.
Good evening, everybody, and I welcome you all to a very exciting inaugural webinar of an ongoing webinar series organized by the Asian Geriatric Oncology Society. So this is one of our first initiatives. I'm sure it will be really enlightening. We'll have a lot of points to discuss, and also through our presentations and discussions, you are also able to have a peek into the world of geriatrics, oncology, and geriatric oncology both, so that overall we can provide a better care for older adults with cancer. So welcome all. So today, with me I have Dr. Nikhil Pathi, who is a medical oncologist, young and dashing medical oncologist from Hyderabad. And he will be sort of talking to us a short presentation regarding geriatric oncology unmet needs, which sort of is going to make the basis of our panel discussion later. So welcome, Dr. Nikhil.
So you will have to unmute yourself.
Yeah.
I hope my screen is visible.
Yes, we can see it.
Yes, sir.
Sure. Good evening, everyone. So this will be a brief sort of introduction type of thing on the unmet needs in geriatric oncology. So this was prepared from some of the excerpts from the article which we have written as part of the AGOS initiative, the unmet needs in geriatric oncology. So just to highlight the problem statement here. So these are some of the data which was taken from the world statistics, the cancer atlas. So we can see that the projections made by the end of 2040, it is expected to rise. The incidence of cancer cases are expected to increase by about 60%. The leading causes of them are lung, breast, and colorectal cancers. The same again depicted in a slightly different manner with age distribution less than 70 and more than 70. We can see that by the end of 2050, it is expected to cross about 30 million in number. And so is the sad increase in the cancer-associated mortality. However, an interesting and encouraging thing is that with the advances in the science and technology, the number of cancer patients, especially older cancer patients, survive longer. So this we can see that in the blue bars, where the projection is around 2040, we can see that a significant proportion of patients beyond 65, 75, and sometimes 85 are also living longer. These charts are from the Indian statistics. This is from the National Statistics Board. So it is expected that people who are more than 60 years and surviving in India without any disease, it is expected to reach about 190 million by the end of 2030. Again, in terms of cancer cases, we get to see here that all cases clubbed together, the incidence is higher when someone has crossed 60 years. So we can see the two bars here, 60 to 64 years and 65 to 69 years. So this is the predominant age group wherein the large number of cancer cases are arising. So again, this shows or tells us the problem that in the upcoming years, it is going to be significant and we all should be ready for addressing the issue. So recently the week article has also published that though it is not great to say that India is now the cancer capital of the world, but I think this is pretty sure pretty soon going to be. So we should all be braced for we should all be ready to face these challenges. So we are aware that with the normal aging process, a lot of changes happen both in the physical, physiological, biochemical levels, and multiple organ systems are affected, right from the central nervous system, cardiorespiratory, genitourinary, which includes the liver, which is a major metabolic mechanism of the body, as well as the renal and the digestive tract, and also the bone mineral density changes which occur. So irrespective of any pre-existing comorbid conditions, with normal aging process, all these systems are a little deranged. So this bears an impact in terms of choosing our treatments, and also in terms of tolerance to various treatment modalities available, especially when these patients are suffering from cancer. When we just looked into the various types of comorbid conditions in patients who are in general adults who are more than 65, we get to see these routine comorbidities, which we also see in our daily practice: hypertension, dyslipidemia, arthritis, ischemic heart disease, diabetes, and so on. So all these have got some implications in terms of the agents which we use, the treatment modalities we use, and also the side effects and tolerance of the cancer treatments. So this leads us to an understanding or the need for having an insight into the various geriatric syndromes, some of which include the dementia, delirium associated with elderly population, nutritional issues, issues with falls and mobility, the incontinence issues, and the other important thing is the polypharmacy, which has got multiple interactions with the medicines which we use in treating these patients. So this is a chart which shows that the left-hand side shows the normal physiological process which occur with aging, and the right-hand side shows some of the mechanisms which can degenerate or degrade into development of cancer. Important among these are the accumulation of repeated genetic insults, the decrease in the genomic stability because of decrease in the repair mechanisms, telomere attrition, and epigenetic alterations. Majority of these can degenerate into cancer. And also in terms of inflammation, repeated and chronic inflammation can sometimes leads to tumor promoting inflammation. There could be altered cellular metabolisms, altered gut microbiota, which can sometimes play a crucial role in development of various types of cancers. Coming to the term GO, which includes geriatric oncology, which is nothing but geriatrics and oncology clubbed together. So pertaining to some of the issues which are specific to geriatric oncology population, the first and the important one is the avoidable delays in seeking the medical care. So that can start well from the patient himself or patient herself because of ignoring the problems, not deeming them to be as dreadful they are or as serious they are. Sometimes the family members delay in seeking medical attention, or the delay can also be at the level of primary care physician who doesn't have a knowledge about or deep insight into the various signs and symptoms of early presentation of cancer in elderly population. This is further compounded by decision-making problems because sometimes the patient is worried, anxious, depressed, and sometimes the family is worried about what treatments the patient has to undergo, how it's going to impact the quality of life, and other psychosocial issues associated with treating cancer in elderly patients. And even if they reach medical attention at some point in time, we also observe that there are certain differences in the pattern in which the elderly cancer patients are managed as compared to young patients in the emergency setting as well as in the ICU. So all these pose a challenge for the patients who are elderly in attaining or taking proper oncologic care. So it is high time that we recognize that the geriatric oncology itself is a newer subdivision in oncology because it seeks to establish patient-centered responses with the help of some of the assessment tools which we know, and thus help to formulate or make a multidisciplinary treatment plan and to execute that to improve the patient outcomes. So our aim, our goal should be that there should be introduction of geriatric oncology-based services. There should be scaling up of the existing services, and should also ensure that more and more healthcare facilities take up these geriatric oncology services across the nation to improve the outcomes. So, well, a guiding model or sort of an inspiration can be taken from the existing palliative care services, which over the last decade has, tremendously grown across India. It works on the basic principle that the holistic approach, which is specially patient-centered, and there is a well balance between or a good interaction between various specialities to arrive at a treatment decision plan. So all these principles can be taken up and incorporated so that assists in the execution or development of an oncogeriatric care model. A word about the comprehensive care assessments. So we are aware that there is an extensive or elaborate comprehensive geriatric assessment which is available. There are certain screening tools wherein we identify a certain proportion of patients who need an extensive or elaborate CGAs. And there are certain oncology specific scales like the CRASH and CAR, wherein we try to predict the toxicity or tolerability of various chemotherapy regimens available in elderly population. Just a brief about the CGA. It includes various domains. Majority of them are non-oncological domains, and it tries to analyze the comorbid conditions, polypharmacy, functional status of the patient, other geriatric syndromes, how good is the social support, and the psychological state of the patient. So based on all these parameters, we try to identify which patients merit an intensive or lesser intensive or no treatment at all. So it gives an insight or adds up to the information which is not routinely picked up on the oncological assessments. And because it predominantly analyzes the non-oncological domains and thereby helps to prognosticate the patients and also improve patient tolerance and outcomes. There has been enough literature also which says that doing a CGA is both cost effective in terms of patient care, and also there is evidence that these patients tolerate the treatment, and at the end of treatment or at the end of discharge, these patients have preserved physical fitness or capability when they have undergone and formulated a treatment plan based on the CGA. However, though it is good and useful, it is not widely practiced because majority of the centers, there is time constraints because the physician sees a lot of patients and he may not be able to do a extensive CGA in all those patients. And so is the issue with resources or manpower who can take in his place or do an elaborate CGA. So there is a dire or unmet need for development of or simplification of certain existing tools, or parallelly developing some of the tools which can assist the use of CGA or complement the use of CGA. For us, again, it becomes more important because we should focus on developing our own indigenous or culturally adapted assessment tools. An example of this one is the Scope-C version 1, which is developed by Dr. Joita and her team. So which tailors or modifies the existing assessments to our basic needs. Another important role in the execution of these geriatric oncological services is the multidisciplinary team. So apart from the other allied specialities like the nutritional, physiotherapy, rehabilitation, the oncologist and the geriatrician play an important or a crucial role, especially for formulating the treatment decision. This is not possible in all areas because the geriatricians are not full-time or not available at many of the oncologic centers. So that becomes a major problem in creating an ideal MDT. Though there has been some improvement in terms of palliative care services at some of the oncological centers, still I think there is a gross need to form a well-balanced multidisciplinary team with all the specialties included, and then base or make our treatments in terms of patient care. Something about the education and training. It is important to communicate and advocate the geriatric oncology. So that requires efforts to improve the public awareness about what geriatric oncology means. It might be through the form of campaigns, or there could be some community volunteers who enlighten elderly patients about the geriatric oncology and geriatric oncological services. The activities which we take should be culturally relevant and community oriented educational initiatives. When it comes to healthcare setting, again, we need to improve the healthcare capabilities or the skills of healthcare workers so that they'll be able to deliver more geriatric onco care services. And when it comes to teaching or education, I think all the postgraduate students should have some bound or fixed curriculum which is in the geriatric oncology, which is imbibed into the existing educational schedule. And also some of them should also have a geriatric assessment as part of their clinical examination or practical examination. And this can also be enhanced through various training programs or fellowships or observerships at centers where there is geriatric oncology, or through CMEs. So all of this leads to more awareness at the community level, awareness at the medical health level, medical community level, so that the resources are better utilized, they are invested properly, and that helps in scaling up or offering more services in terms of geo. So some of the challenges are that the lack of data in the geriatric oncology background, because it is quite important, because when we don't have data, it becomes quite difficult for us to push something into health policy making. So to overcome that, I think we should make every effort to bring in more elderly patients into the clinical trials. So for them, again, age should not be the criteria. And depending on the fitness, if the patients are deemed fit, they should be allotted into the respective treatment arms. And apart from the regular endpoints, these trials also should analyze the quality of life analysis, or the cost benefit analysis, or the tolerability analysis. So they can also make use of parallelly checking some of the assessment tools in terms of tolerance or prognosis. So all these efforts should be made to improve the background knowledge and data in terms of geriatric oncology. Also, there should be more emphasis in terms of health policy and budgeting, and also separate allocation for clinical trials or research in the geriatric oncology setting. And I think the National Cancer Control Program also should have a focus which is slightly aligned into the geriatric oncology specialty, so that because this is going to be huge numbers in the next 20-30 years, so that needs an urgent attention. We should also remember that patients above 60-65 are going to form a major chunk of our country's population, and I think they will have a significant influential election demographic base also. So that they should also have a political agency representing them. Um, and in terms of finances and financial burden, again, the geriatric oncology or treatment pathways are slightly protracted course, and with the advent of novel therapies in cancer management, the expenses are high. They are also going to add up to the existing budgets or finances. So we should also find on ways to improve or increase the economic resources, whether that be government, NGOs, or some other ways to address the issues. So this is nothing but just table which summarize some of the points which you have gone through. That is the awareness, early diagnosis, detection, and integration or development of guidelines for treatment and care, health system integration, that is the geo, getting into the routine medical health services, and then what to be done in terms of research is some of the ideas which are being shared. So when we look at the progress which has been made so far, so at the global level, I think there have been various societies which have formed. They are trying to formulate guidelines on how to treat elderly patients with cancer. There are multiple studies which have looked into various assessment tools or prognostic tools. Some of them are more into specific disease subsets also. And there are certain institutes which have focused more on or solely on geriatric oncology with well-formed multidisciplinary teams. And they are also doing some of the clinical trials there, especially in the geriatric population. When it comes to our country, I think we are making baby steps, but we are in the right direction. And slowly the number of newly forming geo units are increasing. We are trying to imbibe with whatever resources we have available to form available multidisciplinary teams. So we are sensing and seeing that shift in terms of MDT formation. So many of the oncology centers also are imbibing or forming the palliative care specialty into that, and the assessments or growth in terms of assessment tools like the Indianized version or the Scope C version. We are also working on developing various training modules, educational resources, programs like the observership or exchange programs in the geo training programs. And we have seen multiple collaborations between the national agencies as well as international geriatric oncological societies. So these are some of the achievements which we have made, but again, the road is long and we need to push hard really. Thank you.
So Dr. Nikhil, great job. Now over to our respected chairperson, Purvish.
Thank you very much, Prem. You started by, introducing Nikhil as a young and dynamic specialist in geriatric oncology. I think the same applies to you as well, young and dynamic for the other component of geriatric oncology from the geriatric point of view. So I will speak on a few practical issues here. So in India, as compared to other countries, the cutoff is 60 years. And the reason why it is taken as 60 years is because that is where it is identified and recognized by the government as the age for retirement and for benefits of an older person. But there are several geriatricians who treat patients who are younger than 60 years also, which is fair. And personally, I have got 5 family members, close family members, who are 75 years or above, who have been diagnosed with cancer and got the full treatment as if they were young adults. And the outcome was identical, if not better, than those with young adults. So I feel that the important thing is to look at the biological age as opposed to the chronological age. And we need to identify what are the challenges or problems, geriatric syndrome that exist in our patients in our context. And Nikhil clearly mentioned why Scope C is more valuable than comprehensive geriatric assessment. Because there are certain questions which are from the Western world, which are totally irrelevant in our context. And there are certain other things which are very, very important. And one of the most important thing I feel is the difference in what is expected out of the treatment. What the patient expects, the geriatric patient expects, as opposed to what the caregiver wants out of the treatment, may be sometimes difficult or not congruous. And therefore, the 5 key characteristics of expectations of treatment by patients is very important. For instance, do they want the best chance of cure? Or do they want a treatment which will have least amount of side effects? Or treatment which does have minimal or no out-of-pocket expenses? And with 5 lakhs being provided by the government for treatment of all cancers, I think it is very easy to give a good justice to appropriate treatment for our geriatric oncology patients as well. So screening tools which are unique for India, like the Scope C version 1 and 2, are exceedingly important. A few days ago, I had the privilege of going and visiting the Geri-Care hospital in Chennai. And it was pretty impressive how geriatricians have set about providing exemplary state-of-the-art services for our older patients in need of medical treatment. They have home care, where consultants actually go and visit the patients at home. They also have assisted living, where patients with diseases, including cancer, are kept in specialized centers, which are like, patient-friendly nursing homes, where they are provided the treatment as well as the entertainment and interaction with other colleagues. And then they have the regular hospital where more sick patients can get the treatment. And I think availability of all these 3 from the same specialist gives a continuum of care as the patient moves from one place to the other within the same team. So this is, I think, the very important thing, and this is why Asian Geriatric Oncology Society is going to be at the forefront of developing whatever is necessary in our context. In fact, whatever we have done so far has made it so important that organizations like this International Society of Geriatric Oncology and the Japanese Geriatric Oncology Society have entered into collaboration with us. So we are at the right time to develop all the infrastructure and human resource necessary for geriatric oncology. Nikhil showed how the number of patients are going to increase and how customized treatment or personalized treatment will help in ensuring that they have the best possible outcome and they live with cancer or after cancer rather than succumbing to cancer. So with these few words, I will stop here and hand it over back to Prem for the panel discussion.
Thank you, sir. I think a lot of valid points there, which sort of sets a very good pretext to our panel discussion. So, welcoming all my panelists, and we have Dr. Joeta Banerjee, who's a geriatrician from Dehradun, Dr. Ashish Goel, who's a geriatrician from Mohali. He's been one of my foremost mentors from a long time. Then Dr. Shankha Chakravarti, who is currently a geriatrician in Varanasi, a very good friend of mine. Dr. TVTS Tilak sir, who is, I think, one of the very well-known faces, both in conferences and out of it. And Dr. Nikhil, of course, who's already presented. So let me get the ball rolling. So as Dr. Nikhil already sort of mentioned that India is going to become the cancer capital, but the cancer capital part is only one aspect. We already know that India is the diabetic capital, and a lot of older adults are actually belonging to that particular sort of class wherein diabetes is very common. So if cancer looks so sort of, you can say, muddled, then you can imagine that if you just add older adults to the same, how muddled it can actually be. So, I mean, I'm not going to go into the same things that Dr. Nikhil said, but let me just tell that it is one of the most common causes of mortality and morbidity. And what we have all experienced that during COVID, unfortunately, care got a bit delayed. And for whatever reason, obviously the pandemic, it's only sort of increasing and more older adults. So around 62.5% globally, which is a huge number. And 71% were around cancer-related deaths in 2020. And estimated proportion of older adult incidence is around 48% and mortality estimated to around 53.9. So the incidence we are expecting even to increase more. So we can all say that we all have a very difficult job in our hands and we should sort of be buckled up in our seats to take this flight into actually taking care of older adults with cancer in a very great and organized way. So coming on to the panel, I mean, let me just get into a bit of basics here. So, yeah, Dr. Ashish, I mean, just for everybody. So what actually is sort of geriatric care? When we have been talking about geriatric oncology, but what is geriatric care?
That's hi Prem, and let me begin by saying that Dr. Purvish ne jab shuru kiya, he said that you are young and dynamic, and that was not only something which was to do with Nikhil Pathi. I would say that every one of us is young and dynamic, including Dr. Parikh, because if we are talking about geriatric syndromes, geriatric care, and geriatric oncology, then it's not the age that defines youth, and it's not the age which defines dynamism. So we are all younger, dynamic individuals involved in the care of younger and older patients in oncology care. But yes, geriatric care is riddled with its own unique challenges, and it's a difficult journey through the way, because it's not about treating a disease, it's more like treating an individual, and it often requires a multidisciplinary specialty. Although we often tend to believe that geriatrics is nothing but internal medicine for the older persons, and yet a geriatric individual or an older individual or any individual for that matter is a sum total of all his life experiences. And for an older person, these are experiences over 60, 70 years of age which have been put together. With those experiences come in comorbidities. With those experiences come in the challenges, the assets, and the inconsistencies or disabilities which get added on along with each year of life. And so it's not about just caring for an older person or caring for an adult. It's caring for all those years that have gone in to make this individual into a sum total of his experience and his physical and mental health.
Absolutely. And I think that was sort of well said. Just to highlight, Dr. Shankar Chakravarti, if you could just sort of tell me, I mean, just name the geriatric syndromes. A lot of them have been told, but the fact that they can actually affect care in a significant way, especially for an older.
Yes. Good evening, everyone. Am I audible?
Yeah, slightly muffled, but yeah, audible. Yes.
Is all right now?
Yeah, that's better.
Okay, that's great. So thank you, Prem, for giving me this opportunity. This is something completely new to me because this is not the usual field where I work. I'm more into neuropsychiatry and drug safety and other things. But because Prem is a special person for me, so I had to be part of this first meeting. And I think it's a very good initiative. Regarding the geriatric syndromes, I think I would like to highlight through 2 or 3 cases that we recently came up with in the course of our geriatric practice. We had one elderly patient somewhere in his 70s or maybe early 80s was having glioblastoma multiforme and underwent operative intervention, underwent chemotherapy and or rather radiotherapy, and was started on anti-epileptic medications. He was put on brivaracetam, and the patient started developing severe behavioral issues, and we had to shift the patient to phenytoin, which is one of the older trusted drugs. But again, he could not tolerate 300 milligram of phenytoin, and we had to bring down the dose. So it was all treatment based on a sort of a gut feeling of how we could manage, how we could reduce the polypharmacy or inappropriate pharmacy, and the patient was landing up in sort of delirium, so which is one of the classic geriatric syndromes. Very illustrative case. We had one more interesting case who is currently admitted with us because, you know, in medical colleges, usually malignancies are treated by medicine specialists also and by geriatric specialists also. And this is a case of myeloma. It's a diagnosed case of myeloma, but the patient now has got involvement of the vertebrae and the vertebral collapse has happened. And there is impingement resulting in bladder bowel involvement and paralysis of bilateral lower limbs. And we have to get neurosurgical intervention done in such a case and coordinate with the people in the neurosurgery team and also simultaneously continue the chemotherapy for this patient. And this is again a case of immobility, which is again one of the geriatric syndromes that we have. We have another patient of CA prostate, which has advanced despite traditional management that was being given by a very good oncology team in the Tata Memorial Hospital, which has now even got an outpost in Varanasi. And this patient has developed a tumor thrombus of the iliac vein. And there has been significant lower limb edema, and the patient is unable to go on with the daily activities. So this is a case of probably a functional decline, which is again another one of the geriatric syndromes. So geriatric syndromes basically are a combination of signs and symptoms, which are usually multifactorial, can happen because of diverse etiology. And in cancer patients, we expect a lot of them. And probably a geriatrician's role becomes very complex, and we are having to extensively read on each of these topics because these are not common scenarios that we see every day. Easy way out will be to tell the patients, family members to just go for palliative care. Maybe you don't have much of a life expectancy, but the more humane and humanitarian way will be to see how we can make the last few months or years of their life very fruitful so that they can have a comfortable life. So the role of the geriatrician becomes very important in this case. I think I would like to say this much only at this point.
Yeah, thank you, Shankar. I think the way the cases were sort of described, and if there are any students who are attending, it would be really helpful for them, because three very significant geriatric syndromes highlighted through case discussions, and I think that should be something which should remain. So let me come into a bit of combination now. So Dr. Tilak, what about geriatric oncology?
So,
And of course, with your experience with veterans, I mean, older adults in the sort of defense forces state, I mean, they are doing well. I mean, I have seen a lot of cases that you have talked about. But yeah, what about geriatric oncology, and how is it different?
yeah, so first of all, compliments to all of you for this lovely first initial inaugural webinar on geriatric oncology. And Dr. Nikhil very nicely put out the unmet needs. And if you just see geriatric oncology, he introduces beautifully what is it. It's just not a combination of geriatric plus oncology. It's very easy to say it's geriatric plus oncology, but he went on to say what are the various nuances which are required to practice geriatric oncology. And Dr. Purvish also mentioned, as well as Dr. Chakravarti mentioning, that ultimately it boils down to how can I practice oncology, keeping the needs of this elderly person so that he can maintain his current quality of life, and more importantly, his needs and his desires. These are often neglected in some practicing areas, where they say, okay, the person is elderly, so let him just go away, or even though he's very elderly, why not give him the entire treatment, which can be very harmful also. So genetic oncology eventually would mean practice of oncology, keeping in purview the various requirements of these elderly people, their needs and their requirements, along with managing the challenges of managing elderly people with the background of comorbidities, genetic syndromes, etc.
Yeah, absolutely. Thank you, Dr. Tilak. So moving on to how are the older adults with cancer different? I mean, I would just want a geriatrician's view first, and then take an oncologist's view. So, Dr. Joita, how do you feel that the older adults with cancer actually are different?
Hi, everyone. Good evening. And yes, congratulations. We have started the ball rolling. The webinars have started, and it's really a very happy day today. So, Prem, like you asked, we have been working on this for a long time. And the older adults are a different specific set of people who have a specific set of requirements in everything. But when we talk about cancer, these are, much more, and we have to focus on them and we have to treat them in a very focused way, like Tilak said, or like Dr. Purvish said. See, these are people not only with cancer, not only with a disease, and we just can't, just stage the tumor. We have to stage the aging also, how they are aging. It is a staging of the aging process, and also staging of the tumor, and also looking into their other issues, like their emotional issues, or what they want, their autonomy, their support or palliative care. Everything has to be rolled into one. It has to be a holistic care. It cannot be just, geriatric per se, or oncology per se. I mean, it has to be both rolled in together, plus specific things which are which I mean, it's very heterogeneous population, and every person has different needs, and we have to roll out our care plan in such a way that all these needs are looked into. So the older cancer patient is very different. He or she does not come with a tumor or cancer alone. They have lots of comorbidities. They have less coping power. They have issues of, the affect or the effect. They have emotional needs. They have their goals of treatment might be different from a younger patient. It might be more focused on quality of life or support, rather than prolongation of life. So all these things have to be taken care of, and this needs a very well I mean, first of all, it needs a very good, proper assessment and assessment of fitness, so that we don't end up either under or over treating them, and we give them a proper holistic care. I think I'll end here and let the others speak too.
Yeah, Dr. Nikhil, just a quick word on from an oncologist perspective, how do you see them as different?
I guess it starts the other way when we treat geriatric oncology patients. For a young adult with a cancer, we start with what's the disease, what type it is, what stage it is, and then what can we give him. But I think it's the reverse way when it comes to geriatric oncology patients. So there are multiple other things: the emotional aspect, psychosocial aspect of it. What does the patient want? How's the family reacting to it? What are the goals? So I think that's how we see with Giri. And we are slightly more cautious. So we don't want to disturb the quality of life, and that is how it is.
Yeah, coming on to Dr. Tilak. So the challenges which are obviously faced for older adults with cancer. Now, this is more from a patient's perspective. And next, of course, we'll come to the obstacles to treatment from our side, from the clinician's perspective.
So, from the patient's perspective, the challenges include his acceptance. That he's lived a life of dignity, he's lived a life of success, his ups and downs in life, and now he's faced with a so-called a stigmatous disease. You can call it. Still, it's a stigma. Oh my God, I've got cancer. So he has to come to grapple this situation. That becomes his first challenge. Second challenge becomes who's going to take care of me? How am I going to be a burden on my spouse or my children who are going to look after me? How will I travel all the way? Will I be able to handle the treatment? As these are elderly individuals with a lot of wisdom, their myths about the cancer and its treatment, will it be painful? Will I have those kind of challenges which he comes to in their mind? So these are some of the, in addition to, of course, the logistic challenges. Those would be the challenges faced by older adults with cancer. From the therapeutic point of view, the challenges faced by the clinician would be that, like I said, the quality of life still remains the core base platform from where we take off the treatment part. In addition to that, addressing the comorbidities, as mentioned by others, including Dr. Goel, the psychosocial aspect, the emotional aspect, etc. Addressing those would be challenges. Assessments, of course, mentioned by other speakers on how do we assess them fitness towards their cancers. How do we gauge their toxicity, chances of toxicity in a more objective manner? That would be the challenges from our side as a clinician.
Yeah, I mean, just a quick word from Dr. Ashish regarding the fact that, I mean, even in your general practice as a geriatrician also, how frequently does the older adult actually know about their diagnosis? For example, in a person with cancer, it becomes even more difficult because in quite a bit of Indian settings, people don't even know about their diagnosis.
So that's very true, Prem, that we have a paternalistic attitude most of the time, and that not only stems for patient care, but in families, people generally tend to believe that the older person will not be able to accept the diagnosis. They will be frail physiologically as well as psychologically to be able to accept the diagnosis, and they will break down. This is not very well founded, and the details have not been largely studied. But yes, it has been described, established that people tend to keep the diagnosis away from the older persons. They want to shield the older person from the diagnosis to protect them. How far this is effective, how far this is actually the correct strategy or an appropriate thing to do in terms of medical ethics, issues of autonomy, as well as does it really help clinically and individually, has not been very well evaluated and established further.
Yeah, I mean, very right. I mean, maybe a perspective from Dr. Nikhil also. I mean, as a person who must be treating patients, older cancer patients, do they actually know the diagnosis, or does it become difficult for you to even try to discuss the treatment plan with them in presence, because a lot of times they're not even there in the room.
I think the family majority of the times tries to shield the information from reaching the patient, though patient ultimately senses that he has got something grave. So I don't really see the point of shielding it. There are certain ways how we can disclose the information to the patient. They have seen life, they understand, they sense, they can make and take their own decisions. But sometimes it will become really difficult for us to convey or transfer the information with the family as well as with the patients, because this is what happens in OPD practice.
So if I may add one point here, recently we had a patient who was admitted for a surgery of the colon cancer, and we got a scan done and it showed a liver metastasis. So the surgeon said, we're not going to operate, obviously. So we said, okay, we'll start with chemotherapy. And we told the patient that we're going to start with injections first, and then we'll see about the surgery later on. So while we're discussing with the family and this person was there, he suddenly, in his own language, he's a Malayali, he says, wait, tell me first, why is my surgery cancelled? I need to know. I'm the one who's taking the treatment. So it's very pertinent that these points are discussed with the patients. And then we told him that disease is like this. He accepted it, and now he's on treatment.
Yeah, I think in a lot of times it becomes sort of a challenge. And I think with all our experiences, I'm sure. So what about the role of an MDT? I mean, usually we as geriatricians, and of course, I feel even as oncologists, MDT is something which happens a lot. But in the larger picture of actually taking care of older patients, to what extent would an MDT help? Dr. Tilak, you can say first, and then I can involve Dr. Shankar.
Yeah, the role of MDT again, since there are tumor boards are common in most of the oncology centers where we chalk out the overall plan of the treatment for the particular patient. Pertaining to geriatric oncology, even more important because number one, assessment. Number two is tolerance. Number three, assessment of the toxicities which are likely to happen. They are more discussed if the team is in a together rather than individually kind of having consultations for the patient. So MDTs do hold a very important role, especially in geriatric oncology.
Yeah, I would say, of course, I think the role of a geriatrician in an MDT is very important. So yeah, Dr. Shankar, you could just sort of say
yes.
a bit on that. Yeah.
I actually I'll reverse this. I will just ask this to you as a question because, as I said, this is not exactly my field. So I'm a bit curious. Where do you see what role exactly do you see geriatricians performing in a MDT? Like, what type of decision, like in a patient with advanced cancer or even early cancer, an elderly patient being dealt with by an MDT? What role exactly do you feel the geriatrician would be performing? They may do the cognitive assessment, functional assessment, and those are very basic stuff. I mean, even your paramedical stuff, if you teach them, they will be able to assess. But what role exactly will the geriatrician be having? So I think, Prem, if you can better give us an... Yeah.
I think maybe having the moderator immunity, maybe I should bounce it to Dr. Joeta, although I will add later, but yeah. So Dr. Joeta, if you could elaborate on, of course, the role of the geriatrician and our importance in sort of making it better for older cancer patients.
Yeah, so when we are talking about the MDT, here we are talking about the geriatric assessment actually. Yeah, like Dr. Shankar said, we can do a geriatric assessment. The paramedical staff can do functional assessment or maybe, can do the scales and everything. But there should be somebody to actually assess that and understand how the domains are affected. Maybe the paramedical staff won't be able to do that. That is where when the geriatrician comes in, they see what domain is, there is discrepancy in some domain where we need to follow through, where we need to make some subtle interventions. That's all comprehensive geriatric assessment is about. So what is happening now all over the country and everywhere? Geriatric assessment is done as an academic, as an academic exercise. Okay, we have to do geriatric assessment. Geriatric assessment is done. All the domains are being assessed. All the tools are being, used, and papers are being published. But how many times are we actually following those discrepancies, or we are doing those interventions or follow through. That is where the geriatrician comes in. And I think it's a very important thing, because in geriatric oncology, geriatric assessment is the cornerstone. We have to find out the domains that we need to intervene even before we start the chemotherapy. For an example, nutrition. So nutrition, even if there is not a malnutrition, even if there is a risk of malnutrition, we have to intervene at this point before the cancer cachexia sets in. So these are the small things that we pick up and we intervene, and then we present the case, we help the oncologist. It's a complementary thing. It's the oncologist and the geriatrician coming together. We have to do the interventions and help in the quality of life of the patient, and also so that they can there should be the treatment done by the oncologist can be better for the patient.
I have
Dr. Ashish. Dr. Ashish, you just want to
yes,
add some?
please.
Yeah, I wanted to add to that just a simple line that while the oncologist knows what is best and how to treat the disease, it's the geriatrician who will know what's best for the patient who has the disease.
So
Well
my
said, well
question
said.
to that, because you started this discussion, is how do you resolve this who knows best? Because in a corporate setup where we are more likely to have MDTs and boards in actual, rather than in a government setup where it's more of a disseminated practice, how is the oncologist leading the team going to react to, say, a geriatrician saying this patient is not fit enough to go undergo your chemotherapy or your advanced treatment? Because this problem is being faced by clinical pharmacology people. That's the feedback from the corporate sector, where their opinions are usually dismissed by the lead physicians. So how does the geriatrician get incorporated into this system that currently is being run by the oncologists?
Yeah, I think there are several models of care. I mean, to be very frank, in which people can work together. I have been part where I have actually been in the same room where I have done the assessment. The oncologist has sat with me. We both have spoken and we have told. And there is also, of course, there is a separate geriatric oncology clinic in Tata in Mumbai as well, wherein geriatricians are there who are doing it. And then in discussion with the oncologist, the further plan is actually made. So what I would say is it is very much individualized. I can't say that the model can be same in both private and public. But the important part here is to make sure, this reminds me of what Dr. Purvish always says, that if you know that involving a geriatrician in the care of an older person with cancer is going to make their life better, and they are not getting it, means they are not getting the top sort of care. So, I think that is what I would want to say. Uh, Quickly going into the assessment tools, because I think we should give at least maybe 5 minutes for the discussion for audience questions. So we'll try to end at 7:55 and then take audience questions. So assessment tools, yes, they have been talked about a bit already. So I'm just going to keep it very specific. Dr. Joeta, the assessment tools, especially the short one, because scope C is something you can just maybe talk a bit about that and the other ones which are there. And Dr. Tilak or Dr. Nikhil, you can just talk about the chemotherapy calculators and we can just sort of end there and take audience questions. So yeah, Dr. Joeta, quickly.
Yeah, starting with assessment tools, as we have already discussed, we need some kind of assessment. And the comprehensive geriatric assessment is, though it's the cornerstone, and the main domains that we actually see, that might take a lot of time, and that might not be, proper in a very busy oncology clinic. People might not do it. And again, I just wanted to answer Dr. Shanko. Shanko, you are very right. People don't accept it. And that is where our role comes in. And that is why we have started this, the awareness. You are right. It is a kind of a domain thing. The oncologist might think that it's not required, or the geriatrician might want to push in. But when there is awareness and acceptance that both these together can create some kind of a difference in the patient's life, when there is an acceptance, there only we start. And that's why we are all, getting together and spreading the awareness. Now, coming to the tools, so we have got a few screening tools that we are very popular all over the world. So the screening tools are mostly the Geriatric Aid tool or the WEST 13 or the Vulnerable Elderly Survey 13 questions tool, and we have some abbreviated geriatric assessment tools. So all these tools are somehow they are incorporated in assessment of older cancer patients in some clinics. But the main problem with these tools are they don't first thing for Indian patients, Western part of the world, and also these tools do not cover all the domains of the comprehensive geriatric assessment. They are, short screening tools, which will again, lead to more of a detailed geriatric assessment. And it has been found that, for these screening tools to be good, they should be very specific and sensitive also. And it has been found that most of the tools are not that sensitive or specific to pick up, false. They do have false positives also. And so these are, it is a general consensus among geriatricians that these tools are not good for screening of older patients, and we should rather go into the assessment of all the domains that are professed in the comprehensive geriatric assessment. Maybe we can't do the CGA. Here, I would like to talk a little bit about the scope C that we have developed and which we have developed for the Indian patients and validated on the Indian patients. So this is, here we have taken care of all the domains of comprehensive geriatric assessment. And also there's a part where we have focused on the supportive care, which is very important in the whole care, continuum. So the supportive care of the patient is very important. Whenever we start trying to do the treatment, the supportive care and whether the patient will be able to go through the treatment, the financial issues, these all have to be taken care of. And also, of course, the toxicity part, which the medongs will be telling now. So here I would like to, we don't have much time, so we would rather wrap up saying that the screening tools are good to start with, but we should rather focus on comprehensive geriatric assessment tools or a more detailed tool which takes care of all the domains that are very important for assessing a patient with cancer, like, the functional part or the emotional part or the polypharmacy, the comorbidities, the geriatric issues like falls, which are very important, incontinence part, and the supportive care. These things have to be taken care of.
Yeah, so
I think, Prem, I will hand over
Dr.
to
Tilak.
the...
Yeah, Dr. Tilak. So quickly, just about maybe just the chemotherapy calculators, and then if possible, let us take a couple of questions. Yeah.
So the commonly ones which I use routine in my practice is the CARG, the cancer and research aging, the one, and it gives me a good idea of objectively modifying the treatment to assess the toxicity in the patients, which I use routinely. There's also another one called CRASH. So there are two ones which we routinely use in chemotherapy calculators for geriatric oncology patients. It has actually made a difference in the time I've started using CARG in deciding the doses for my patients over the last about 2 years since I have become aware. And like Dr. Joyita mentioned, I think the most important word here is awareness that yes, the oncologist and geriatrician have to be together.
Yeah, so thank you all the panelists. I think the last thing which I want to just say is we all want to focus on the quality of life. And the way ahead, obviously, is through organization. So there is a International Society of Geriatric Oncology, and of course, there is EGOS. So please join our Asian Geriatric Oncology Society. You are more than welcome to help us in trying to make it a better place for older adults with cancer. So thank you. So I think we can maybe take at least some questions. And I think Dr. Ashish has to leave. So thank you, sir, for being there. So if at all there are any quick questions, I think there were a lot of questions, but we have Dr. Purvish who has actually answered most of them. So that's we always say it's always great to have our Brahmastra. So he is our Brahmastra. So yeah. any questions? We can take maybe one quickly. If at all any people have specific questions which you want to ask live, because there have been people who have sort of asked some questions online already. So yeah, if there are none, then of course, thanks a lot for everybody
Sir, we've received two
who
questions.
has been here, and thanks a lot, Doctor. Yeah, there are questions. Oh, that's great. How frailty is important. Okay. Commonly used geriatric assessment tool. Okay, I think, yeah. Shankha, just quickly take it, and then maybe the final word can be given. The next question can be answered by anybody. Yeah. So how is
Question,
frailty important? Just quickly,
Yeah,
Shankha.
frailty is important. Yes, so I don't think there are very good interventions for frailty, and it's a poorly understood phenomenon even for geriatricians when not dealing with oncologic patients. So exact interventions are quite dubious, and we have to go for whatever new evidence comes in managing the frail patients. It is sort of common sense decision that in frail patients who have less a body normal physiological response of their body to different stresses is pretty much deficient. It will not be a prudent idea to go for any more invasive procedures and more intense chemotherapy regimes or radiotherapy regimes. And probably you need to go for more of palliative care. But sometimes even more complex cases come where we have to take a decision, even in frail patients, where we have to go for aggressive treatment. I'll keep that for some of the future meetings because we have some really interesting cases which we can discuss in the future meetings.
Yeah, absolutely. Thank you. And of course, I think Scope C would be a good tool. So yeah, I would like to sort of close now. Thank you. Thanks everybody who have joined. And yeah, thanks everybody who have joined. And we will be convening again in May. So this is going to be a sort of a monthly sort of an initiative. And we are obviously hoping to get more interesting case discussions, topics. So thank you. Thanks everybody. And thanks a lot, especially Kashish and team for helping in the organization part. Thanks a lot.
Thank you, everyone.
Have a very good night.
Thank you. Thank you so much.
Good night.
Thank you, everyone. It's just a start.